Hello, everyone, and welcome to the December 2025 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. I'm Mike Rickles from the University of Pennsylvania.
And I'm Alice Cheng from the University of Toronto, and we are your co-hosts for this podcast series. Welcome to the last month of the year, everyone. We made it.
We made it indeed, Alice. And what fun facts do you have for us for December?
Well, Mike, on a bit of a side note, we actually just had our Diabetes Canada Canadian Society of Endocrinology and Metabolism annual conference in Toronto. And I want to give a shout out to Kim, who came up and told me that she particularly enjoys these fun facts about the different months. So thank you, Kim. And I am happy to know that there is at least one person who enjoys these as much as I do. Now, continuing on with the food theme from last month, I think all of you are eagerly awaiting to hear what food days exist in December. And surprisingly, there is no Turkey Day, in case you were wondering. December actually holds the following: National Cookie Day, Brownie Day, Gingerbread House Day, Cocoa Day, Pumpkin Pie Day, Candy Cane Day, and of course, Fruitcake Day. Of all of those foods, Mike, which one's your favorite?
Well, for me, December is definitely the month to use up those pumpkins. So whether it's pumpkin pie or pumpkin bread, although I have to say I'm partial to pumpkin bread because it rewarms easily and it's best when you slice it, drop it in the toaster, and then spread a little butter on to melt in and
I have never had pumpkin bread, Mike. I think we need to fix this. The next time we see each other, I feel like you need to bring me some pumpkin bread.
very easy. That they call them quick bread. So
Okay. You're gonna have to educate me next time. Now, for me personally, when I look at that list of foods, I would say fruitcake, not a fan. I've never understood the concept of fruitcake, and I apologize if I've offended anyone just now. But cookie, absolutely love cookies, especially the soft cookies. I could eat cookies all day long. So next time I see you, Mike, I'd like you to bring me pumpkin bread and cookies, actually, if you can.
well, I'll have to get my daughters to help me on the cookies, but yes, love it. And now, on a more serious note, this episode marks our 40th episode of Diabetes Care on Air, which I can't even believe. And so I have to just say huge thanks to our many, many guests now over these past 40 episodes, our listeners for all your invaluable support, and you, Alice, for leading us through this podcast series.
Well, thank you, Mike, but I'm going to thank you for leading us through this podcast series. And it's been an absolute pleasure to work with you. And of course, we've got a lot more episodes to come. At the same time, though, I also want to shout out to our producer, Nicole Valenzi, who is responsible for making us sound far more eloquent than we actually are, very skillfully and seamlessly removing all of our ums and ahs and our stumbles. So a huge thank you to you, Nicole, for everything that you do for us.
Yes, thank you, Nicole, so much for all your help and support. And on that note, let's launch into the December episode of Diabetes Care on Air, in which we'll be interviewing authors of feature articles from the December issue and run through our popular rapid exchange segment where we'll each pick 3 articles of particular interest to us this month.
Excellent. Make it so. One of the feature articles from the December 2025 issue of Diabetes Care is entitled Type 2 Diabetes Remission, a systematic review and meta-analysis of non-surgical randomized controlled trials by Dr. Diana Sherifali and colleagues on behalf of a pan-Canadian integrated knowledge translation type 2 diabetes remission advisory team. We have an all-Canadian interview today, so I am totally pumped. I am thrilled to be joined by the lead author, Dr. Diana Sherifali, professor in the School of Nursing at McMaster University and lead of the McMaster Evidence Review and Synthesis team, along with co-author Dr. Megan Racey, senior research coordinator at MERST. Welcome to you both, Diana and Megan, and thank you for agreeing to be part of this podcast, and a huge congratulations to you and your colleagues.
Thank you, Alice. Thank you. We're so pleased to be here.
So let's launch into it. Type 2 diabetes remission remains obviously a hot topic, and certainly one that people with newly diagnosed type 2 diabetes ask about in the office. In fact, if you Google the phrase, "Can I reverse type 2 diabetes?" there are literally pages and pages and pages of websites and videos, most of which are claiming to have the answer. Now, if the answer already exists, at least according to the internet, why did you feel this was an important topic to address?
So thanks for the question, Alice. Well, the pages of websites and videos that claim to have the answer to type 2 diabetes remission are often, as you can imagine, sensationalized and sensationalizing what's available and seizing on the opportunity of what people are ultimately looking for, and that's hope to make their type 2 diabetes go away. So they often oversimplify or misrepresent what type 2 diabetes remission actually means. And they rarely account for individual variability, sustainability, or even safety. So there's often a gap between what is shared publicly on the internet and sort of rigorous evidence-based science. So one path for type 2 diabetes remission may not be something that everyone can do or available for everyone. So, with this rapidly evolving field of research, and obviously this is our clinical area of research as well, the timing seemed right to kind of cut through the noise and take a comprehensive evidence based synthesis of what truly works. So, we took that lens. And prior to this work, there was no meta analysis that specifically examined various approaches. So, not just nutritional behavioral approaches, but also multimodal approaches that include pharmacotherapy, because we know that there's huge, sort of this diabetes renaissance with GLP-1s, SGLT2s, all of these medications. And so, we're coming at this from the lens of understanding who is being offered type 2 diabetes remission, what is effective, what are the interventions consist of, what are those components, so we can ensure that we're having conversations supported by evidence and not just further stigmatizing, shaming, and blaming individuals. And unfortunately, research can often focus primarily on the individual capability and capacity, but we know it's much more than that. We know that there's systems that can support and sustain, but also structures and systems that can be barriers in the first place. So interventions for type 2 diabetes remission should also investigate these systems and where things are being implemented so that it's pragmatic, realistic, and we're not just blaming individuals again.
Love it. So you're really taking a holistic, and I know that term gets used a lot, but that truly holistic approach to this, as opposed to, as you said, all the sensationalized stuff that's on the internet. So what were the specific objectives of the study?
So we had two objectives to our review. So the first was to assess the effectiveness of these pharmacological and non-pharmacological type 2 diabetes remission trials. So that's looking at what works. And then the second objective is to characterize those components of these type 2 diabetes remission interventions to see what are they made of, what's the recipe, and how do we make remission work.
Excellent. So how did you go about actually doing the study then?
So we followed rigorous systematic review processes to conduct this study. So that includes following PRISMA and Cochrane guidelines, and we registered our protocol on Prospero. We searched two different databases for peer-reviewed randomized controlled trials about type 2 diabetes remission in adults. Our review includes studies published all the way up till April of 2025, so very recent. We focused on non-surgical interventions. So that means any combination of pharmaceutical or behavioral trials with a control group were eligible, and it had to be conducted in people with type 2 diabetes. And the control group, we wanted it not to contain any intervention components, so we could truly see the difference between what the intervention was doing and how it was working and whether it was effective. We screened all the citations in duplicate and independently and verified all of our data extraction with the studies that met our inclusion criteria. We actually extracted outcomes for data that were based on the quadruple aim framework. And these outcomes were ranked by our interdisciplinary team of experts so that we could see not only what was important to us as researchers, but what's important to people with lived experience, healthcare providers, and what outcomes they were looking and interested in. And then we conducted a random effects multi-level meta-analysis to also examine the results by intervention type and follow-up duration.
Okay, so extremely comprehensive and really involving all the appropriate stakeholders, right? Which I think is really critical to research these days. Now, Megan, you very clearly outlined the two specific objectives, right? One was what works, and the second one was what does the recipe consist of, if I can paraphrase what you said. So let's start with objective number one, which was what works. So what did you find with respect to that first objective to assess the effectiveness of these interventions?
Yes, so we found 18 randomized control trials from 11 countries that met our inclusion criteria. So 10 of these studies were the nutrition, multi-component type of behavioral, and 8 of the studies included some sort of pharmaceutical with other components as well. Most studies included individuals with type 2 diabetes that had a duration of diabetes from as little as 14 months to as long as almost 7 years. And participants were mostly insulin naive. So 10 of our included studies had participants that had never taken insulin before, but 5 studies actually did include participants who had already been on insulin. We found that both types of interventions significantly increase the likelihood of safely achieving type 2 diabetes remission. The likelihood of achieving remission was actually greater for the non-pharmacological studies. So those multi-component studies that included anything from nutrition, physical activity, health coaching, and things like that. And there was also other benefits. So beyond remission, even just working to achieve remission and that goal, those studies all saw a significant reduction in A1C, body weight, improved quality of life, and lower risk of hypoglycemia. But we did, interestingly, when we looked at the kind of follow-up and duration of these studies, as the studies were longer, we saw that remission rates declined over time, especially in those non-pharmacological studies. So this really highlights the challenge of sustaining behavior change.
Absolutely. And then how about the second objective, which was the recipe components? What did you find there?
Yeah, so this is a really, really interesting part of our review. We were really eager to tease apart this recipe. I think not surprisingly, we were confident that these remission interventions would work. So finding that they were effective for that first objective was not too surprising. But teasing apart what are these interventions? What's the recipe? We used what's called the tidier checklist to break down each intervention into its core components. And so what we found is that most of the pharmacological interventions combined medications like metformin, insulin, GLP-1 receptor agonists, and SGLT2s with some component of lifestyle changes. And they were typically delivered in more clinical settings and by regulated healthcare professionals. The non-pharmacological interventions included total diet replacements or very low calorie diets. So 6 of the 10 included studies actually used these approaches. So these could be diets, liquid diets, as low as 600 to 800 calories a day. They often did, again, combine these nutrition strategies with things like structured physical activity, behavioral support, including health coaching and peer support. They also use technology-enhanced tools like wearables or smartphone apps, or even one study used AI-driven nudges to text and remind participants about their goals and what they're working on. And then there was also some studies that use psychological support to look at barriers and stigma with type 2 diabetes. And again, these non-pharmacological studies were delivered in a variety of settings, but almost always by a team of interdisciplinary healthcare professionals. So that could be doctors, nurses, pharmacists, dietitians, along with community health workers or coaches. And the last thing I'll say is that tailoring was really common. So the interventions were adapted to individual needs and also delivery formats, often combining in-person, phone, email, and virtual options to connect with the healthcare professionals.
Okay. So we heard about the fact that, yeah, these things work and that there's multiple components, and multimodal, I think, is the term that you use, which I think is a great way to describe it. So then my question is, what's holding us back from wider implementation? Because the implementation of this, and you already mentioned sustainability is an issue. And also, what advice would you have to our listeners who may be thinking about wanting to help people implement strategies to achieve type 2 diabetes remission? What would some of that advice be?
Right. So I think implementing anything from randomized controlled trials always needs to have some deliberate thinking and thought behind it. So I'm not sure that they're necessarily barriers or challenges, but perhaps things for people to consider as they go to implement some of the, strategies that are articulated in this review. So I think the first thing would be feasibility. We currently have a little bit of insight from nutritional sort of total meal replacement interventions that were found in the course of doing this review. But beyond that, achieving type 2 diabetes remission in the real world is not well understood, as there's obviously implementation issues with putting into practice clinical trial protocols in real world settings. What we do know, interestingly, is that type 2 diabetes remission has been offered in specialized clinics, in primary care settings. It can be done virtually according to what the evidence is suggesting. So it's clear it can land in various centers, but where it is best implemented and integrated is with a team-based approach, as Megan said. Sustainability is something else that we're looking at. So these studies have specific criteria for participants to be eligible for the trial, and the protocols may not be acceptable for everyone kind of in the real world as they, try to balance their life and work and other responsibilities. So I think moving from clinical trial evidence to real world practice really needs to consider patient or the participant's needs, preferences, cultures, and of course, cost to individuals. The third thing I would consider is accessibility. These studies are just one piece of the puzzle to help us understand that sort of recipe for what does a successful remission intervention look like. The other pieces of the puzzle are context, settings, and circumstances that support or hinder or challenge people's access to these strategies. And then I think the final piece I would probably highlight is equity. And so in addition to all of what we've talked about, this may be a bit provocative, but type 2 diabetes is not always a democratic disease. And so it tends to impact people who are more vulnerable from sort of societal, structural, economic barriers. And so the programs offered must be accessible and equitable to all. And if we can learn anything, maybe we look to diabetes prevention programs to see how did they break down those barriers? How did they reach people where they're at and provide interventions for folks that, may not have that sort of social and economic standing to access such interventions. So I guess our advice for listeners who may be helping individuals implement such strategies is that for long-term success of these interventions, there needs to be a shared decision-making approach between the person, but also the interdisciplinary or multidisciplinary team of healthcare professionals that considers that patient preference, context, setting, lifestyle choices, culture, etc. And again, it goes back to why we did this. And this was recognizing from the literature that there's more than one approach to do this. So what works for one person or in these trials may not work for another person. So adaptation and behavioral support, along with the tailoring that Megan talked about, are going to be key, absolutely vital. Type 2 diabetes is not one individual's fault, but there's a myriad of ways that we can work with people and teams of healthcare professionals to make these lasting changes that result in improvements along their remission journey. Improvements such as mobility, their quality of life, and in fact, some mental health outcomes like depression. So it's a marathon, it's not a sprint. And with the right strategies, type 2 diabetes remission can safely occur.
You've left us a lot to think about there, Diana. So what are the next steps then in research in this area? Because there's obviously still a lot of unanswered questions. So what are some of the next steps?
Yeah, well, we know, again, we have a little bit of insight from the evidence. We also know that in the Canadian landscape, people are thinking about this thoughtfully across different regions and provinces in Canada. But we also need to think about this from a broader view from the individual, but also the systems and structures level. So policies, clinical practice, etc. We also have not explored relapse and whether individuals can go into type 2 diabetes remission again. So I think there's some really cool things that are coming out of this. And, I think as any good explorer and researcher, you're always coming up with more questions. So thus far, trials have, relatively crudely described identified populations and who qualifies for studies and is offering sort of the opportunity for remission. But I think in the future, more work can be done on who is eligible for remission and kind of further refining the definition of remission, but also that kind of relapse, if you like, and then do they go back into remission? Again, I think more research needs to be done in the space of trials and sort of looking at taking RCT evidence and making it more feasible, sustainable, accessible, and equitable for all people wanting that chance and that hope of type 2 diabetes remission. And so we're doing a lot of work in the implementation space, working with primary care providers. In our context, that's the conduit into the healthcare system. So we look forward to being part of research from that sort of community primary care lens in Ontario, across Canada, and beyond, hopefully.
Wow, that's all I can say. So thank you. Thank you very much to Drs. Diana Sherifali and Megan Racey for sharing your expertise with us. And again, congratulations to you and your colleagues for this study, which to me, I think has really increased our understanding of the pharmacologic and the non-pharmacologic interventions for type 2 diabetes remission, but really helping us to identify the do they work, but critically, what are the key components or core ingredients of that recipe that need to be there. And throughout everything you were speaking of, I kept thinking about the whole person, the entire context of that individual, but also of the system, of our healthcare system and of our society, and how all those pieces need to fall together to allow this to be successful. But obviously still a lot of questions about sustainability and how to improve that. So lots of food for thought. Thank you both so much for joining this podcast. And I encourage our listeners to read the full article in the December issue of Diabetes Care.
In the December 2025 issue of Diabetes Care is a feature article entitled Inadequately Controlled Type 2 Diabetes and Hypercortisolism, Improved Glycemia with Mifepristone Treatment. This paper reports on the treatment phase of the Catalyst study. I'm delighted we have joining us the article's corresponding author, Dr. Vivian Fonseca. Dr. Fonseca is a professor of medicine and pharmacology, chief of the section of endocrinology, and assistant dean for clinical research at Tulane University School of Medicine in New Orleans. Welcome, Vivian.
Hi there.
So congratulations, Vivian, and to your co-authors on your feature article. The Catalyst study had two parts, and I want to ask you to explain that in a moment. And for our listeners, Mifepristone, which is perhaps better known as an antiprogestational agent, is also a glucocorticoid receptor antagonist. So I'm hoping you could walk us through what was known about Mifepristone use in the treatment of Cushing's syndrome, complicated by hyperglycemia, prior to Catalyst, why and when we should suspect hypercortisolism in our patients with type 2 diabetes, and how that set up the objectives for each part of the Catalyst study.
Okay, let me give you a little background to why we did the Catalyst study. First of all, we've known for a long time that Cushing's syndrome is associated with hyperglycemia, if not full-blown diabetes, that may be difficult to control because of significant insulin resistance related to glucocorticoids in the circulation. We also see a lot of people treated with steroids and their blood glucose goes high. And we know that from practice. What was not well recognized is that Cushing's syndrome is an uncommon condition. We know that, but there may be other milder forms of hypercortisolism that are not easily recognized. They don't have the full-blown features of what Harvey Cushing described in the 1930s and treated surgically with pituitary surgery. We also know that it could be pituitary or adrenal or ectopic, and there are ways to differentiate those. There have been reports from Europe and South America on what they were calling mild autonomous cortisol secretion. And mild meaning you don't have the full-blown Cushing syndrome, but the cortisol levels are a little bit elevated. autonomous because you could not suppress it fully with dexamethasone, which is a diagnostic test that has now been standardized. And there is some data that after dexamethasone, we want to see it down to zero that's totally normal, but we used to recognize less than 5 as being okay and more than 5 as being Cushing syndrome. But maybe people who are 1.8 post-dexamethasone, 1.8 and above, had poorer outcomes. So 1.8 was selected as a cutoff. And the Italians described this was fairly common in the diabetes population. But there were small studies, little anecdotal reports, none done in the US. And a few years ago at a meeting, a few of us were discussing some of these. And we were also faced with the problem of some people's diabetes is just very hard to control. We have wonderful drugs now. Everything has changed in the last 10 years. Well, but despite all those drugs, often combined with insulin, there are people who are uncontrolled out there. So what's going on in them? Could it be that this cortisol problem is prevalent in this population? And we talked to a variety of people about this issue. CORSEP, which is the sponsor of this Catalyst trial, said that they would like to explore this further. And they also offered to fund the study and provide Mifepristone as a treatment. So we thought this was a good opportunity. By the way, Mifepristone was developed as a non-specific steroid hormone blocker, including progesterone and cortisol and perhaps a few other steroid hormones. So we planned the study very carefully. We had multi-center representative across the US, over 1,000 patients with diabetes uncontrolled, defined as greater than 7.5. And we excluded people who may have false positives, lack of suppression, such as shift workers, women taking oral contraceptives, pregnancy, and so on, severe psychiatric disease. And, when we talk to people, we say, well, you may not get that many because they have all these drugs out there. We were very surprised. We divided the study into 2 parts. First part was prevalence, which is already published in Diabetes Care. And we were surprised to find that 24% of this over 1,000 people that we screened with the dexamethasone suppression test had a non-suppressible. By non-suppressible, I mean more than 1.8. In fact, it was 3.5. And we measured dexamethasone level, which was over 400. And we had a cutoff of 140, so the mean was over 400. Clearly, these people took their dexamethasone and did not suppress. So they had an abnormality of cortisol metabolism. We did ACTH and DHEA. CT scans showed that a third of them had some abnormality in the adrenal gland. Over 20% had a nodule or multiple nodules. So here was potentially surgically treatable disease that we have not detected in diabetes centers. It's very telling, I think. And in 24% of these people, their A1C was about 8.6%. So then we moved over to part 2, which is the subject of this new paper, where we randomized some of these people, those who were eligible or wanting to do it and so on, to Mifepristone or placebo. And you could up-titrate the dose. And we saw a 1.4% reduction in A1C with Mifepristone and hardly any drop with placebo. And the drop started occurring fairly soon. And because some people had hypoglycemia, we down-titrated their diabetes medications, many coming off fast-acting insulin, some reducing and even coming off long-acting insulin as well. A few stopped their GLP-1. So these were people who were taking insulin plus GLP-1 plus SGLT2 inhibitors and able to come off them, yet dropping their A1C by almost 1.5%. That, in my opinion, is a spectacular result. How did we get there? My take on this is that this is a precise way of treating. Rather than doing what we traditionally do in diabetes, give it to everybody and see if it works. We are identifying who's most likely to respond and treating them. And we get a very good result. In addition to reducing the dosage, we saw some additional benefits, a moderate degree of weight loss, about 5%, but most of the weight loss was around the waist. So we are probably decreasing metabolically active fat. Now, it wasn't without problems. A lot of people got typical well-known features of Mifepristone side effects such as hypokalemia and also steroid withdrawal syndrome, feeling fatigued, not quite right. And then we see this in practice. Now, one of the reasons for this may be that we were using a dose that is approved for treatment of Cushing's syndrome, starting with 300 milligrams a day. Whereas these people did not have the full-blown syndrome. They had mild disease. Very few of them had many Cushing's features. They just had uncontrolled diabetes, despite taking many medications. So they got withdrawal, and some of them actually stopped the medication. A few were able to up-titrate, and those who went to the higher dose had an even greater reduction in A1C. So there was a suggestion of a dose-response relationship there. Another thing that occurred was that the blood pressure, which was 125 mean systolic at baseline, went up to 131, mainly because we did not up-titrate. In a randomized trial, you don't know who's getting placebo. And accompanied by hypokalemia, there is a good explanation for this. And that is when you block cortisol, the levels rise so high that it binds and stimulates the mineralocorticoid receptor. And you could, in practice, block this and block the hypokalemia as well with something like spironolactone. That's what we do in practice. So there are a lot of implications here. First of all, we've identified what kind of person you would screen. At least it's such a simple screening test. An overnight dexamethasone suppression test. People who have uncontrolled diabetes despite many medications, people taking more than 3 drugs for diabetes and 3 drugs for hypertension. 35% of them had this abnormality. And in general, many of them were taking other things. Some were taking analgesics, antidepressants, features that are associated with Cushing's syndrome, yet they didn't have full-blown classic Cushing's syndrome.
So this reminds me of our approach to resistant hypertension, where you think about primary aldosteronism and have an algorithm for determining surgically correctable disease or medically treatable disease. And so I'm wondering if you could take us through your approach following the dexamethasone suppression test when you identify those who have a non-suppressible cortisol. For your intervention phase of Catalyst, you did exclude those with presumed pituitary Cushing's or those that had an adrenal lesion that was surgically amenable. Can you take us through how we consider those branch points to treatment with mifepristone?
That's a very good question, but just let me correct you on one thing. We did not know that these people had adrenal tumor. At the start, we selected them purely because they had difficult to control diabetes.
Right. I mean, going into the treatment phase, there were inclusion-exclusion criteria.
But even there, we did not exclude people who had tumors. So some had tumors, but especially bilaterally. We didn't want surgery. Some didn't want surgery and were willing to participate. Some wanted to have surgery, and that was fine. We compared those with tumors and those without tumors, and there was no difference in the response. This is the first study in what we're calling non-neoplastic hypercortisolism. It's really very interesting. So you're raising a very good point. Recently, the Endocrine Society issued new guidelines on hyperaldosteronism and had recommended screening for it in everybody. Take this, everybody with hypertension. That's a tall order. It's a simple test, renin and aldo. So I think we should be screening everybody who has difficult to control diabetes, 3 drugs for diabetes, 3 drugs for hypertension, a simple dexamethasone suppression test. If they're normal, don't proceed any further. If they're abnormal, you need to explore, is this pituitary, is this adrenal, is there something surgically correctable, or you need medical treatment? But that's not in the guideline yet. So it's really up to the ADA guideline committee, standards of care committee, to consider this.
So you talked about then when treating in practice, the consideration for adding mineralocorticoid receptor antagonism to mitigate the potential side effects of glucocorticoid receptor antagonism. And so what would be your recommended advice to mitigate side effects such as hypokalemia or an increase in blood pressure in individuals with type 2 diabetes and hypercortisolism?
I use spironolactone. I'm also, this is purely off-label, considering using lower doses of mifepristone. And down the road, we will be exploring other medications that may not have as much of the limitations of mifepristone. So, for example, you could have a more specific blocker of the steroid hormone receptor that does not block the progesterone receptor. So women could take it, for example. And there are some in development like that. We are also looking at doing a study called Momentum that's currently ongoing, just as of today, fully enrolled, looking to see how many people have both hypercortisolism and hyperaldosteronism. Not necessarily always tumorous. Some could have just hyperplasia of the adrenal gland for reasons we just don't understand. If you will allow me to speculate here, I think we are all subject to little hypercortisolemia due to the stress of our lives, all these cell phones and emails and EMR reminders that we get every day. And maybe at some point, it is not suppressible and takes over and makes our diseases worse. And it's something that we need to consider.
Any final takeaway messages for our listeners?
My major takeaway from this is that we need a little bit more precision in our approach to treating diabetes. We need to identify abnormalities that way you can target the therapy directly. And a good example is MODY. You know, you had people we treated with insulin responding to sulfonylureas, people who with the other forms of MODY not responding to metformin, which is the first line therapy that we use, and responding to sulfonylureas. We also have late onset type 1 diabetes where they don't respond to any oral drug because they have antibodies and need insulin. So here is another way of identifying a problem. I don't think we should be screening everybody with diabetes just yet because we don't know what it is in well-controlled diabetes. We have only studied people who had difficult to control diabetes. But look at that population. People who have more than 3 drugs for diabetes and a few other little nuances there, and 3 drugs for hypertension, having A1Cs of 8.6, 35% of them are likely to be positive. You know, can I say that it's almost embarrassing to me that some of these people were in my clinic and I could not control their diabetes and had missed this abnormality, including one person who had an adrenal nodule that I had not looked for.
So it's an important lesson for all of us to take back to our own practices and consider the patients that we may have missed. Hypercortisolism contributing to the challenges faced in control of their glycemia and weight, and now have an approach by more broadly applying glucocorticoid suppression testing with dexamethasone, and really this demonstrated efficacy for having an available agent, mifepristone, for improving glycemic control in these individuals whose diabetes can be shown to be complicated by hypercortisolism is really just tremendously fascinating and important, and no doubt will be hopefully making it to our guidelines in the near future. And Dr. Vivian Fonseca, thank you so much for sharing your expertise with us today. I want to encourage our listeners to access the full article in the December issue of Diabetes Care. Let's move on now to the Rapid Exchange segment, where Alice and I will discuss articles we found of particular interest this month. Alice, why don't you get us started?
Sure, absolutely, Mike. So my first pick for this month is a reminder as well as a wake-up call. Doctors Marianne Becker and Jansje Weiskorn and colleagues from Belgium, Germany, and Austria performed a retrospective cohort study to identify children with type 1 diabetes and familial hypercholesterolemia and analyze their lipid-lowering therapy. It's important to remember that T1D is common, we know that, estimated prevalence of about 1 in 400 children in Germany. But so is heterozygous familial hypercholesterolemia, or FH, which is an autosomal codominantly inherited disease whereby the LDL receptors do not work well and affected individuals have very high LDL cholesterol. Now, individuals with FH are asymptomatic until there is symptomatic atherosclerotic disease, so there is importance to try to identify them earlier. Now, heterozygous FH is actually more common than type 1 diabetes, with an estimated prevalence of 1 in 275, or some studies say 1 in 313, in the Caucasian populations. Now, T1D and heterozygous FH are each associated with increased cardiovascular risk, so it's not surprising that together the risk would be even greater. So in this study, they analyzed the data of nearly 42,000 children with pediatric stage 3 type 1 diabetes from 384 European centers as part of the Diabetes Prospective Follow-up Registry. Those with repeated LDL measures greater than 4.9 millimoles per liter, or 190 milligrams per deciliter, were classified as probable FH, and those with LDLs between 4.1 to 4.9 millimoles per liter, or 160 to 190 milligrams per deciliter, were classified as possible FH. Now, the reference group were those with LDLs below 4.1, or 160. Now, the prevalence was as follows. 1.2% had possible FH, and 0.56% had probable FH. Now, this makes the prevalence of probable FH to be around 1 in 215, which is higher than previously reported. Now, these two groups had higher BMI standard deviation scores, higher A1C, and were more often female. Interestingly, though, only 8% underwent any genetic analysis. And what was particularly concerning, though, was the low use of lipid-lowering therapy. Only 29% of the probable FH group and 20% of the possible FH group were actually receiving lipid-lowering therapy. But according to guidelines from around the world, children with type 1 diabetes older than 8 to 10 years of age with an LDL greater than 3.4 millimoles per liter, or 130 milligrams per deciliter, or in some cases over 4.1 or 160, are supposed to be on lipid-lowering therapy. The exact reasons for why there was such low treatment could not be elucidated from this retrospective cohort study, but it certainly serves as a reminder and wake-up call to not miss the opportunity to identify these very high-risk individuals early, to not only start treatment early, but also to reverse cascade and identify other affected family members early.
Thank you for sharing that one, Alice. I, for one, was not aware the prevalence of familial hypercholesterolemia was that high. And so I think it's natural that we feel having type 1 diabetes in childhood is enough and lowering elevated cholesterol is an adult problem. But clearly, these data highlight the importance of considering and addressing both diagnoses early in their disease course. My first pick examines calcium channel blocker use and the risk for type 2 diabetes. Recent evidence supports that the calcium channel blocker verapamil may slow the progressive loss of beta cell function in recent onset type 1 diabetes. Now, Dr. Julian Sacre and colleagues in Melbourne, Australia, compared the incidence of type 2 diabetes developing in users of verapamil compared to other calcium channel blockers in a population-based cohort of over 90,000 Australians. And of the almost 5,000 verapamil users, there was an incidence rate ratio of 0.77 with a 1.3% absolute risk reduction for developing type 2 diabetes at 6 years. And while this risk reduction is modest, these results suggest larger risk reductions might be observed among individuals with hypertension selected for increased type 2 diabetes risk, and future prospective investigation may be warranted.
And that's very interesting data, Mike, and I thank you for sharing it, because when I first heard about verapamil in the type 1 diabetes space, I thought that was very cool, because verapamil is sort of an old drug and this whole repurposing of old therapies is becoming more common. But then now, if this could apply in the type 2 diabetes space, that's very exciting. And I think it's important to study because the typical calcium channel blocker that's used is usually not verapamil when treating regular hypertension. I think most people often turn to amlodipine because of some of the data around cardiovascular risk reduction when used with RAS blockade. So if it turns out verapamil actually reduces the risk of type 2 diabetes, that may change what we do. So very cool. We'll certainly keep our eyes and ears open to see if anything more comes from that. Now, my second pick follows along the theme of the importance of early intervention. So Dr. Yang Wang and colleagues from China and Europe investigated the association between BMI transitions from childhood to adulthood and the risk for cardiovascular kidney metabolic syndrome, or CKM syndrome, and its components in midlife. They used data from the Hanzhong adolescent hypertension study of nearly 2,000 participants aged 6 to 18 years who were followed for a whopping 36 years into midlife with a mean age of 48 years. They were categorized into one of 4 categories based on BMI change from childhood to midlife. So the first category was normal to normal. So they went from normal BMI in childhood to normal BMI in adulthood, so they were deemed the control group. The second group was normal to elevated, meaning they went from normal childhood BMI to an elevated BMI as an adult, called the incident group. Then there was the elevated and remained elevated. That group was called persistent. And then there was the elevated to normal. So elevated BMI as child and then normal BMI as an adult, and they were called the resolved group. Now, the greatest risk of developing either intermediate or advanced stage CKM compared to those with persistently normal BMI was seen among the incident group, which was the group that transitioned from a normal BMI in childhood to an elevated BMI in adulthood, with odds ratios that were quite high of 5.19 to 6.70. For the specific components, those individuals had higher risks of left ventricular diastolic dysfunction, subclinical kidney damage, albuminuria, and metabolic abnormalities. Now, interestingly, those who were persistent with the elevated BMI from childhood to adulthood also had higher risk, but not to the same magnitude as those who went from normal to elevated. What was also interesting, and has implications for intervention, was that for those whose elevated BMI in childhood resolved to normal BMI in adulthood, their risk of CKM was similar to the group who had normal BMI throughout. So in other words, maintaining normal BMI throughout life or achieving weight normalization by adulthood were associated with lower risks of CKM syndrome. This, to me, highlights the need for early and continuous interventions to address childhood and adolescent obesity because of its implications lifelong.
Yes, Alice, better to be early, but also wonderful to learn that it may never be too late to receive benefit from efforts that result in achieving normal or reduced body weight. My second pick follows the theme of evaluating a type 1 diabetes intervention for type 2 diabetes. Automated insulin delivery has recently been shown to benefit individuals with insulin requiring type 2 diabetes. However, the Center for Medicare and Medicaid Services in the United States, also known as CMS, requires a low C-peptide for insulin pump coverage unless there's evidence for islet autoimmunity with positive antibody markers. Dr. Earl Hirsch from the University of Washington in Seattle and colleagues from the 2IQP study group, of which, by way of disclosure, I'm a member, evaluated data from a randomized trial of automated insulin delivery with the Tandem t:slim pump and Control-IQ Plus technology in adults with insulin requiring type 2 diabetes. And in this analysis, categorized the participants into high and low C-peptide cohorts based on CMS criteria. There were 195 individuals in the high C-peptide cohort and 59 individuals in the low C-peptide cohort, each randomized 2-to-1 between automated insulin delivery and a continuous glucose monitoring, or CGM, control group. Both treatment groups experienced identical 0.8 percentage point reductions in hemoglobin A1C after 13 weeks of automated insulin delivery that were significant compared to the control condition of ongoing insulin management with CGM. So this finding of equivalent benefit in terms of glycemic control, irrespective of C-peptide levels, indicates that having a low C-peptide for approval of automated insulin delivery should not be required.
So first of all, I'm sitting here in Canada listening to you speak and think we don't have access to automated insulin delivery for those living with type 2 diabetes at all, let alone with the C-peptide criteria. But this is great, right? I think this really helps to broaden the population that can benefit from. I like to refer to automated insulin delivery as having an extra diabetes brain, right? So that's essentially what automation is. So this diabetes brain is helpful for really anybody with diabetes based on what we're seeing here, and that the C-peptide should not be a rate-limiting step. So very useful information for one day if it ever becomes an option for us in Canada to use AID in those living with type 2 diabetes. For my final pick, I'm going to carry on the theme of early identification of risk. Now, just to provide some background, heart failure is common in diabetes and has no symptoms in early stages. We have disease-modifying therapies to help prevent heart failure and or reduce its complications, such as RAS blockade, SGLT2 inhibitors, and GLP-1 receptor agonists. Now, biomarkers that can be measured in blood to detect early heart failure in asymptomatic individuals who may benefit from these disease-modifying therapies are the natriuretic peptides, specifically N-terminal pro-brain natriuretic peptide, or NT-proBNP, and B-type natriuretic peptide, or BNP. Although the prognostic value of these tests in type 2 diabetes was already established, there was limited evidence in type 1 diabetes. Therefore, Professor Rodica Papasui and colleagues in the United States examined the prognostic role of these natriuretic peptides in people with type 1 diabetes or type 2 diabetes without known heart failure to predict future heart failure or death. Using Optum's de-identified market clarity data, they identified over 116,000 adults with type 1 diabetes or type 2 diabetes without known heart failure who received an outpatient natriuretic peptide test between 2017 and 2023, and the group was followed for up to 7 years. Nearly 3,000 people in this group had type 1 diabetes, with the rest having type 2. Approximately 40% of individuals with type 1 or type 2 diabetes had elevated levels of natriuretic peptides, specifically BNP greater than or equal to 50 picograms per milliliter, or NT-proBNP greater than or equal to 125 picograms per milliliter. Bottom line, these increased levels were highly prognostic of incident heart failure or mortality among those with either type 1 diabetes or type 2 diabetes, supporting its potential role as a screening and risk stratification tool in a broader diabetes population.
Very interesting, Alice. And it would be great if these biomarkers could also predict those individuals most likely to benefit from the addition of specific disease-modifying therapies. My last pick examines the risk of acute pancreatitis and biliary events after initiation of incretin-based therapy for type 2 diabetes. Individuals with type 2 diabetes are already at increased risk for experiencing both acute pancreatitis and biliary events. And the potential for GLP-1 receptor agonists and DPP-4 inhibitors to increase those risks remains an area of active debate. Mr. Yi-Chen Fang and colleagues from Harvard Medical School in Boston used Medicare and 2 U.S. commercial claims databases to identify 3 pairwise cohorts of propensity-weighted individuals with type 2 diabetes and no prior history of pancreatitis or biliary disease, initiating either a GLP-1 receptor agonist or SGLT2 inhibitor, that's one pair, a DPP-4 inhibitor or an SGLT2 inhibitor in a second pair, or a GLP-1 receptor agonist or DPP-4 inhibitor in a third pair. And each comparative cohort included over 1.2 million individuals. And what they found was no increased risk for acute pancreatitis with either a GLP-1 receptor agonist or DPP-4 inhibitor compared to SGLT2 inhibitor. But they did see a modest increase in risk of biliary disease with both incretin drug classes. And that risk was similar between the GLP-1 receptor agonists and DPP-4 inhibitors. So this comparative safety data supports the need to consider biliary risk rather than pancreatitis risk when initiating incretin-based therapies.
And I would say these data are certainly reassuring, right? Because we've been asking or been asked that pancreatitis question for a number of years now, and the answer has been no, it seems like it's okay, it seems like it's okay. And then now we have 1.2 million individuals in each of these pairings to support the fact that it seems to be okay. But yet the biliary signal has shown up in those randomized controlled trials, the large CVOTs. So this, again, is in keeping with that. So good to see this information. Well, this brings us to the end of the December 2025 episode of Diabetes Care on Air. Thank you to Drs. Diana Sherifali, Megan Racey, and Vivian Fonseca for sharing their expertise with us.
And a big thank you to you, our listeners, for tuning in, not just to this episode, but for your wonderful support in 2025. Remember that Diabetes Care is continuing to take submissions of original art for consideration to be included on a future journal cover. Don't forget to subscribe to get notifications about new episodes of this podcast. Thank you for listening. Happy holidays, and look forward to seeing you in the new year.